Thank you, Erica, for that excellent example of e-learning as well. I'd also like to welcome everybody today, especially those of you who've flown in from out of town. I was really happy to see the participation from people who don't live in DC. We've been talking now about this triple challenge of health workforce production, as well as some examples of how it can be overcome through the WHO recommendations, recommendations from the Global Commission. So just to summarize again, this challenge includes the Human Resource for Health Challenge, which is characterized by shortages of skilled workers, the imbalanced distribution of workers, migration. I don't think we've mentioned much about migration, but the fact that health workers are educated in one country and then leave that country to work in another. And the challenges around skills mix with different mixes and cadres of health workers, as well as specializations. The education and training challenge we've talked about as well, and the limited production capacity. At the moment, there's this estimated shortage of 7.2 million doctors, nurses, and midwives, but all of the medical, nursing, and midwifery schools combined in the world are producing less than 1 million a year. So if you think about not even factoring in attrition in the workforce, it's going to take more than 10 years to ever reach that figure, and by then we'll have moved on to the next deficit because of the growing population. So there's really a limited capacity of production. And then we talked also about the weak links between education and health systems and the need to strengthen those, and those calls for reform in both instructional and institutional areas. And again, the investment challenge. The resources are extremely limited to talk about scaling up and transforming education, and something needs to be done to increase investment in this area. This is just another example of this poor distribution and the severe crisis or critical shortages in sub-Saharan Africa and Southeast Asia over on the left of the graph, and the relative surplus in other countries such as Europe. And you know, we see here Americas, but we know even in the United States we have shortages of nurses and physicians. I thought this is a new publication that came out last month, a follow-on to the Global Commission, written by Lincoln Chen and Nigel Crisp, that shows an opportunity, actually. If you see in some very resource-constrained countries, the skills mix is shifting, or there's innovation in terms of using more or making more use of paraprofessionals, so mid-level type health workers, similar to, say, a physician's assistant here in the United States. And the opportunity that we might pull from that in terms of how workforces could be remodeled or reconstructed in resource-constrained settings. And we know, for example, that technical surgeons in Mozambique and lady health workers in Pakistan have actually been shown to increase not only access to health services, but also improve health outcomes such as child survival. So this is something to think about in moving ahead with transforming and scaling up education. So what is CapacityPlus doing? Kate already mentioned that we're the global project dedicated to human resources for health, funded by USAID and PEPFAR, launched in 2009 and led by IntraHealth. And what we're working to do is in line with the WHO recommendations and the Global Commission to support efforts to move health workforce education from academic centers and into academic systems or into the health system, and to embed education firmly within those systems and communities with the goal of developing competent and qualified graduates. And similar to the production pipeline that Erica lives and breathes, we do as well. And I'm trying to show here how that production pipeline, how schools actually are the intersection between health systems and education systems. And where along this production pipeline, there are a number of critical stages, like we mentioned, student admissions, quality assurance of institutions, particularly when private sector education is becoming more and more prevalent, and there's a need to ensure the quality of that education. And then within the schools, the instructional and institutional capacity, the certification and licensing of graduates upon graduation, support for recruitment and placement, and moving into the service sector. Traditional approaches to addressing pre-service education or health workforce education have tended to focus more, as Estelle mentioned, on the instructional components. And CapacityPlus is trying to expand that and focus as well on institutional components such as governance, management, infrastructure, teaching staff, et cetera. And so to highlight some of our approaches, we're looking not only at increasing investments or targeting investments in institutions, but also the more efficient use of existing resources inside those institutions. And I'm going to just talk a little bit about these 5 areas: the bottlenecks and best buys approach, the school management package, an approach we're using to estimate the cost of producing a graduate, some strategies that we've identified for overcoming gender barriers, and our contributions to PEPFAR's medical and nursing education initiatives. So for the bottlenecks and best buys approach, this involves working with local stakeholders to review a school's production capacity, and then identify bottlenecks that impede the institution from successfully accelerating expansion, and then defining together with those stakeholders what would be the priority actions or best buys that could have the largest potential for overcoming those barriers and scaling up production. And unfortunately, this slide came out a little bit more busy than I was hoping. But what I was trying to show here is that we look across those areas on the left, so that these different categories of education that are critical, and they go across the pipeline. So for example, we look at student, but we don't just look at students while they're in the institution. We're looking at the recruitment of students, how they progress through the programs. Are they retained? Do they pass their certifying exams? So the bottlenecks assessment is quite broad in its scope, and it involves doing a situation analysis with stakeholders in an institution. If several schools are conducting bottlenecks assessments at the same time, we'll also do a desk review of the health system, of the education system. And then within the institutions, there are options to look at surveys of faculty and students, et cetera, to dig a little bit more deeper into what the perceptions of bottlenecks might be. We've done bottlenecks and best buys approaches in 7 countries in more than 50 institutions, mainly focusing on nursing, midwifery, community health extension workers in Nigeria, health assistants in Ghana, and in Kenya, some medical schools. PEPFAR's Nursing Education Partnership Initiative aims to strengthen nursing and midwifery education systems and is working at the moment in 5 African countries, in the Democratic Republic of Congo, Ethiopia, Lesotho, Malawi, and Zambia, and we're fortunate to have a representative from HRSA here who will be leading a table on NEPI. As a partner in this initiative, we've collaborated with ICAP, Columbia University, and the NEPI steering committees in the DRC and Ethiopia to adapt and apply the bottlenecks approach. and assess midwifery and nursing education capacity in those countries. And then ICAP has moved forward based on those assessments to develop work plans, multi-year work plans with several schools. The advantage of working together with many schools, we've been able to show and address some of the more systems level issues. For example, what we talked about for faculty development, attracting faculty into, attracting workers into the education sector, and strengthening regulatory bodies. In the DRC, there is no council that regulates credit schools or certifies graduates. An example from Nigeria, we worked with initially 13 schools to conduct bottlenecks assessments, and we found through the desk review that there were very high dropout rates. This shows from admissions through completion of the program and then passing of national exams, larger than 50% loss of students, which is not a very efficient system. So the goal that was set with stakeholders through those assessments and the bottlenecks and Best Buys process was to decrease this loss or the dropouts. So rather than try to input more students into the system, the goal was to actually increase those who actually came out of the system. Some common examples of bottlenecks, there are, we found, as I mentioned, outside the control of the school, often the poor quality of secondary education, as Erica mentioned, which limits the pool of candidates who can be absorbed into the education system. And then a very common and critical bottleneck is the shortage of qualified teachers and clinical preceptors, and the weak accreditation systems. And then within institutions, I think a lot of us who work in this area have seen this over and over again with the student admission policies, large class sizes, dropouts in final years, infrastructure shortages, damaged classrooms, limited materials, et cetera, especially if you're working in resource-constrained settings. Some Best Buys from examples from Nigeria, Mali, and Ghana are pedagogical and curricular programs. So basically, training of tutors, training of faculty, bringing them up to date in current clinical practices. There tends to be, or at least in Nigeria, separation between the classroom tutors and those in the clinical practice sites, and they don't work in clinics. They stay in the classrooms, and so they become outdated. So some of the ways to improve, especially the quality of education and ensure that those students graduate and are certified, is through the faculty development. And then procurement of materials, and especially those used for simulated practice for anatomical models and skills labs, et cetera. Of course, upgrading the facilities, the infrastructure, the classrooms, and scholarships to at-risk students in their final years, because one of the bottlenecks we found was that students toward the final years, especially if they've failed the certifying exam and need to retake, they drop out. So scholarships to get them through that final year and graduated. And one very interesting Best Buy that we've found in Ghana was for a one-time investment of less than $40,000. A health assistant school was able to enroll 100 additional students through increasing their faculty by 5 educators and building just 1 additional classroom. So that's an example of what we're trying to do with very targeted investments. Some results so far in Nigeria, working with schools for about 2 years now, is we estimate that we'll have benefited about 8,000 students over the next 5 years, and we're already seeing increased graduation rates, 5%, but it's statistically significant. Another approach is the school management package, and here the goal is really to improve the efficiency and the effectiveness of the use of resources, human, financial, material, and knowledge resources. And we know that a lot of the senior leadership in schools moves into those positions not necessarily because they're managers, but because they're either good teachers or academicians. And so one important approach is to look at training leaders in management, but also a process that we are promoting, which is assessing a self-assessment process, looking at these several different areas of management, and then developing, I'll move on, developing and setting priorities around a management scale improvement plan, implementing that plan and monitoring it through a computerized open source dashboard, the Dean's Dashboard that we are developing, and then renewing the cycle. The Dean's Dashboard is one of the components of the school management package, and it's being used in Ghana at the Garden City University College. We're also at Walter Sisulu University working with them in South Africa, as well as Watakanela College in Botswana, to develop indicators across different management categories. Here's an example of in Garden City University where they wanted to increase their number of students over a set period of time, and so they used the Dean's Dashboard to monitor progress toward that goal.
Just a few more minutes.
Okay, I'm going to move on. So another area is our costing work, and here again we collaborated with the Nursing Education Partnership Initiative to develop a methodology to estimate the cost to produce a graduate, and also looking at the constraints as well, the fixed assets constraints to producing a graduate, and looking at, for example, if a bottlenecks assessment has been conducted, what would be, if certain interventions are put in place, what would be the additional cost or the new unit cost. We piloted that in South Africa, and we found some interesting results where, for example, 90% of costs are among are salaries related to faculty, and the costs, of course, are increasing as students go through their clinical years. At the moment, we're working now with the NEPI initiative to conduct costing studies in Ethiopia with 2 colleges of health sciences, and also in Democratic Republic of Congo. And Steve Musau is here, and he will lead one of the tables to talk more about those costing studies. And then, as I mentioned before, we're looking also at important gender barriers in pre-service education. And here are some examples of some of those gender-related issues that can prevent students from moving through education programs, such as gender stereotypes, lower admission rates of female students. We've found even in the bottlenecks assessments issues around sexual harassment, or fees being levied when students need to leave for pregnancy, and for female students in particular, unsafe living conditions, and limited student availability to to safe facilities. What we've done is compiled and analyzed peer-reviewed literature and gray literature to identify some interventions that can be applied to overcome some of these barriers, and produced a technical report and a technical brief on strengthening the health worker pipeline through gender transformative strategies. And these are just a couple of the recommendations that are found in those documents. Developing sexual harassment policies, allowing for re-entry into programs after pregnancy, allowing for maternity leave for students and faculty, childcare, etc. And then finally, but not last but not least, our work with partnering with the Medical Education Partnership Initiative. We're working in 3 areas with 3 of the initiative's technical working groups on graduate tracking, using our experience in human resource information systems to help develop graduate tracking systems, in the area of e-learning to help 11 institutions develop e-learning strategic plans, and also in the area of community-based education. And we have a couple representatives here from MEPI who will be leading a table on that topic. So this is to say that I've tried to give a very broad overview of what our work, and there will be an opportunity now after a short question and answer session to speak in more detail with various representatives on different topics. And these are the topics that are listed in your program. And you'll have an opportunity to visit one table per each round. Okay? Thank you.